Dr. Harpreet Kaur Kapoor, who's a consultant for the CBM in India, Dr. Padma Paul, who's from CMC Vellore, Dr. Uday Gajiwala, who's been a consultant and has been part of investigating multiple such cluster outbreaks across the country. I think Dr. Mahesh G, who's passionate about the legal aspect.
Yeah, as Dr. Kaushik has already told you, this particular IC is based on the guidelines for managing cluster endophthalmitis, and these did come out just these are very recent, just came out last quarter of 2023, and I'll be just covering some of the definitions and identification of a cluster endophthalmitis. And of course, this doesn't just cover the clinical aspects, but also other aspects like how to communicate with patients, reputation management, because some of these, like, of course, we diligently go ahead with treating our patients, but then there are times when we face such crisis and we really don't know what to do. It shouldn't happen to anybody, but in case it does, so these guidelines will be of help to one and all. So in the present day era, I would say cluster endophthalmitis outbreaks are quite rare because of advances in technology, and we follow certain protocols. Surgery is much safer, but in case it happens, it can have devastating consequences. So we know that cataract surgery is one of the most common surgical intervention worldwide, and incidence of endophthalmitis in the developed world, as reported, is between 0.08 to around 0.1% after cataract surgery, as per the ESCRS guidelines. And if we talk about India, so there is limited, there are reports available in published literature, and so mind you, this is published literature. When we are talking about, the range is between 0.04 to 0.2%. It's in India. So when we come across a case of endophthalmitis, it might be just a sporadic case, but we have to kind of get into the details, dive deeper to find out whether that particular case is part of a cluster, or is it actually just a sporadic or isolated case. So it's seen that isolated cases are usually because of patient-related factors, and it is because of the commensals usually. So staph and strep species have commonly been found to cause isolated cases of endoph. And then talking about cluster endophthalmitis, usually it is, you do find a common source of contamination, and the common organisms responsible for these are gram-negative bacteria, Pseudomonas being one of the main culprits there, and fungi. So what really are the potential sources of contamination? So it's been seen and published that it might come from the surgical instruments. Here we are now talking about cluster endophthalmitis. So, and most of the reports have kind of come out with the contaminated ophthalmic solutions as being the culprit. So it's the balance salt solution, ringalactate, trypan blue, viscoelastics, whatever you are using. And then, of course, in our setting, like in a country like India, I would say a low resource setting, we do commonly use the phaco probe and the tubing also. So phaco probe is kind of used between cases, several cases rather, sometimes through the day. And then the tubings are also used, again, they are reusable sometimes. And then, of course, the intraocular lenses and the solutions, they are also sometimes reported to be responsible for a cluster, and intracameral injections. Having said that, I think we should not forget that, of course, we can kind of, say that, okay, the industry, or it was because of the commercial products that we landed up in such a situation. But just the same, it is pertinent that we follow standards of practice in the OT. Standard sterilization protocols are followed for sterilizing the OT, and even by staff. So that, of course, that discussion is for some other day, because there are several best practices which we need to follow to ensure that we don't end up in such a crisis. In fact, I have, I think I should share this. In one of the live workshops, there was a surgeon who was operating, very fast surgeon, and then when somebody asked him that, he or she was not really sterilizing the instruments in between cases. And when he or she was asked regarding why he is following that practice, so it was like the answer was, I'm saying in Hindi because impact better होगा, मैं इतनी जल्दी सर्जरी करता हूँ कि बैक्टीरिया को टाइम ही नहीं मिलता अंदर आने का. So there we are. That is our country for you. And in case, so I hope everybody understood that bit. Coming to the definition of cluster endophthalmitis, well, if you search literature, you will come across several reports and various definitions which are being followed for defining cluster endophthalmitis. But we are happy that AIOS did come up with certain guidelines which were based on ESCRS and the Royal College of Ophthalmology guidance also. So they are all now, and we are now supposed to follow this particular standard, because you don't find this in books, a certain standard specific definition of cluster endophthalmitis. So it is recommended that we follow this particular definition, which I would say is occurrence of 2 or more infections in a single day from one theater, or if you come across repeated post-operative infections under similar circumstances spread over a period of time. So if you come across a case of endophthalmitis, you need to really dig deeper and find out and follow your surgical cases also very strictly. Be vigilant about it as to, to find out if there are other cases happening. So in case you come across a repeated post-operative infection and happening by the same surgeon, the same staff, consumable batch numbers are very important to be monitored, and the same operating room. So you might be, dealing with a cluster there. I would also like to touch upon, normally when we talk about cluster endophthalmitis, we are thinking about CAM situations and cataract surgeries done there. But then this is a recent kind of, there's another epidemic happening now of post-injection cluster endophthalmitis. This, of course, the incidence reported is between 0.028 to 0.056%, and more so in the Indian setup, because we are using injection bevacizumab we know that it comes in vials, and we prepare aliquots to kind of just because of just to save cost, we are dividing the preparation there into and using it for several patients. So that is where the contamination happens, and during the compounding process, you can kind of contaminate the aliquots which are prepared, and the infection can happen and can reach the patient. And here is just a report which is from PGI. They did have several cases of endophthalmitis there. So once you've confirmed that you are dealing with, that you have, or you are actually kind of, looking at the, you land up in a situation where you have endophthalmitis and you are suspecting that it might be part of a cluster. So then you follow this much talked about traffic light system, wherein if it's a green alert, you perform a review, check and ensure that the standard theater protocols are being followed, preventive measures are in place, and this heightened vigilance should be in a place if it's a green alert. And if it's an amber alert, then of course it calls for urgent review, a complete microbiological workup, stop regular surgeries, only emergency surgery should be done, and if possible, don't start even regular surgeries till you've identified the cause. And red alert, of course, is like, that sometimes some organization might land up with, say, tens and hundreds of cases following high volume camp surgery. So then, of course, this straight away you are following the red alert there. And it would call for a detailed investigation, and closure of operating rooms to investigate the cause of an outbreak. And then the steps, of course, to be followed are that you form an expert team, stop surgeries, review protocols, and of course the patients have to be, don't forget your patients, and usually doctors would be kind of, just focusing on the patients, but just the same, effective communication with the patients and the relatives is equally important. And you have to dive deeper and try to investigate the cause of the source of the infection, and not to forget reputation management and medico-legal considerations are equally important. So while I would say everybody, all doctors, we know by nature, we are kind of, we just go for the patients first and we try to save the eyes. But just the same, you never know what the lawmakers, how the public would react, what the lawmakers would come up with. So essentially, not just, I would say, save eyes, but yes, do save yourself as well. And I would leave the rest to my eminent colleagues, and they would be kind of, covering each aspect as we go along the next 60, 70 minutes. Yeah. Thank you.
Thank you so much, ma'am. I think we have a panel discussion or a question answer. Honor to invite Dr. Mahesh Anmugam, a colleague of ours from Shankrai Hospital, Bangalore, who heads our vitreoretina ocular oncology, and yesterday was recognized with the C.N. Shroff Award by the All India Ophthalmic Society. So, sir is going to be sharing with us the ophthalmic management. Cluster has happened, but the patient still is important. So, what are we going to do about the patient?
Thank you so much, Dr. Kaushik. So, let's look at ophthalmic management of cluster endophthalmitis. Essentially, it's the same. Ophthalmic management of cluster endophthalmitis patients remains the same. Actually, you treat the endophthalmitis like how you would treat any other endophthalmitis patient, but then there are some differences. So let's look at a clinical example. Here we have a patient who has a hypopyon on the first day after an uncomplicated surgery. So usually a cataract surgeon tends to believe that it is TAS. So it's possible it's TAS. So but how do we differentiate a TAS from endophthalmitis is the first question that arises. So TAS, as all of us know, it follows an uneventful surgery, and it usually happens on the day of the surgery or the first day of the surgery. There is intense post-op inflammation, and the patient does not have much pain. There is fibrin in the antechamber, and corneal edema from limbus to limbus, and no vitreous involvement usually. But what we need to understand is that TAS can be a cluster as well. So endotoxin contamination of balanced salt solutions, as well as inadequate instrument sterilization and preparation, can give rise to TAS as a cluster. So that's something which we need to differentiate from a cluster TAS versus a cluster endophthalmitis. So let me give you an example. This happened to us. So it happened to only me. There were 3 of us in the vitreoretinal department, but in one particular theater, one particular machine, I used to do vitrectomy for macular surgeries, like a macular ERM or a macular hole, and fill up the eye with partial fluid air exchange. And then about a week or so later, the patient presented with intense posterior segment TAS. So the A in TAS is anterior segment, but then we used to have a lot of inflammation, vitreous membranes, as you can see here, in the posterior segment in these patients. So I was ripping apart everything to see what are the cause for this particular issue. I could not find anything. The sterilization indicators were perfect. Everything else was perfect. Then in desperation, I told the engineer to rip apart the machine. So if there was something wrong with the machine which is going on. So as he was about to rip apart, he pulled out this tray out here. So that had a filter through which the air from the OT was drawn inside and pumped into the eye during fluid air exchange. And this filter, this is how it looked. So this filter was supposed to be replaced, and somebody forgot to replace it. The engineer did not know that it had to be replaced. And this resulted in the posterior segment TAS. And all the patients where I had done a partial fluid air exchange were the ones who had this inflammation. So it's something which we need to differentiate a posterior segment TAS from, or an anti-segment TAS from an endophthalmitis. As I mentioned, it can occur as a cluster. So this is the tabular column which differentiates the two clinically. Time the TAS occurs much earlier on the day of surgery or on the first day. There's hardly any pain at TAS. Conjunctiva and lid are normal. That's a very important sign differentiating between TAS and endophthalmitis. Corneal edema is limbus to limbal in TAS, and iris has a dilated pupil in TAS in contrast to a small pupil in endophthalmitis. IOP is quite high in TAS. It can be high or low in endophthalmitis, and therapeutic response is very good to steroids. In contrast, in endophthalmitis, they worsen. And TAP is negative in TAS. Of course, it can be positive, and most often it may be negative as well. So we have a patient with first day hypopyon, doesn't all the time mean it's TARS. It can be a very, very virulent gram-negative organisms. So whenever we are doubtful, what I would do is to do a TAP and then inject an intravitreal antibiotic plus a steroid and then look at the specimen and then take the subsequent treatment based on how the patient progresses or worsens. So as I mentioned, the first day post-op cluster endophthalmitis is a very, very bad sign. So it's likely to be a gram-negative organism, and studies have shown that most often it's Pseudomonas aeruginosa is the most common organism associated with cluster endophthalmitis from India. And it's likely to be consumable related. So it could be an infusion fluid or a viscoelastic. So you are likely to get a lot more patients in the subsequent days coming up with this particular infection. And the other implications are they rapidly progress gram-negative organisms and with a high chance of loss of eyes. And if it is a gram-negative organism, in contrast to what the endophthalmitis vitrectomy study, endophthalmitis vitrectomy study showed, we do give a parental antibiotic. It could be an IV antibiotic or a parental antibiotic is preferably given. And we have to treat these patients with intensive topical and intravitreal treatment and less threshold for early vitrectomy. So most often we jump in and do a vitrectomy in these patients to save the eyes. So what is the next step once we identify a patient with endophthalmitis who is part of a cluster, admit the patient, and most important, check vision. This is medically necessary, always check vision. And next step is to perform antechamber tap or vitreous tap as soon as possible. And if fundus view is not possible, do an ultrasound to see how the status of the retina is and vitreous is. So these are all common steps for any endophthalmitis. And next is to obtain a specimen. Specimen is extremely important in this situation. I'll tell you why. So specimen can be AC tap, vitreous tap, corneal scraping, or an explanted intraocular lens. And then subject it to everything possible. Do a PCR to see if you are able to identify the bacteria, and then also do a smear culture, preferably in 2 labs. So that we increase the chance of identification of the organism. So what do we do? It's usually the same: grams, games, and fungal staining, culture, aerobic, anaerobic, and fungal. And it's preferable to plate the specimen in the OT itself. Let's not send it out of the theater, particularly if you don't have a functioning microbiology department in the hospital. Get the culture plate and put the specimen in, plate it into the culture media in the OT itself and send it out. So why is it necessary to identify the organism? Because it helps us to treat the other patients. And also it helps us to identify the source of the infection. Let me give you another example. In my previous place of work, we suddenly had a bunch of patients with fungal scleritis. Totally uncomplicated surgery, could be a macular hole. Diabetic patients tended to have a little bit increased incidence of the fungal scleritis. Nearly 40-50 patients, we suddenly found that we had fungal scleritis. Once again, we went around breaking our head as to what was the reason for it. Finally, I went into the theater and found that there was a gap between the false ceiling and the wall, and took a specimen from the top of the false ceiling and found it was Aspergillus flavus, which was the exact same organism which was found in the patients. So it's the identification of the organism helps us to identify what is the source of the organism, and also to treat the other patients as well. So how about medical management of endophthalmitis? It's essentially the same. Topical antibiotics. What is preferable is either a fluoroquinolone plus an aminoglycoside. Most often it's moxifloxacin and tobramycin or amikacin, half-hourly or hourly. Topical steroid if you are not suspecting a fungal endophthalmitis 6 times a day, and topical cycloplegic. Subconjunctival antibiotic I usually don't give, but you can give this in addition to an intravitreal antibiotic as well as a topical antibiotic, but not in lieu of either of the two. So you can give it in addition to. So vancomycin, ceftazidime, or dexamethasone can be given subconjunctivally. Most important is to give an intravitreal antibiotic. And it's essentially vancomycin plus amikacin. But what we most often give is vancomycin plus ceftazidime. It's a standard dose of antibiotics what is given. And intravitreal steroid, dexamethasone 400 micrograms is something which I would give in addition to the antibiotics. Other intravitreal antibiotics, because like in a cluster, it need not be an organism which is usually susceptible to the common antibiotics. So we may have to look at other antibiotics. So other intravitreal antibiotics which can be given are moxifloxacin, that's a dosage 100 to 200 micrograms, linezolid, piperacillin, tazobactam, or colistin. These are the other antibiotics which we need to keep in mind when we are managing a cluster. Antifungals can be voriconazole and amphotericin. These are standard ones, which is what we usually give. Systemic antibiotic, as I mentioned, in a cluster, I would prefer starting a systemic antibiotic. And if in case it's not gram-negative, turns out to be gram-positive, probably you can stop the systemic. But I would prefer to give antibiotic in every possible way in a cluster to manage these patients the best possible. And what are the systemic antibiotics which we give? Usually give it for 5 to 7 days. Ceftazidime, garamycin, amikacin can be given. Linezolid, vancomycin, imipenem or meropenem can be given. These are parenteral, IV antibiotics. Oral moxifloxacin, gatifloxacin, trimethoprim sulfamethoxyl can be given orally. What is this based on? This is based on a study which showed that like best documented agents achieving therapeutic levels in vitreous are meropenem, linezolid, moxifloxacin. And acceptable are vancomycin, cefazolin, ceftriaxone, ceftazidime, imipenem, and trimethoprim sulfamethoxyl. But these are useless. So don't give ciprofloxacin, levofloxacin, aminoglycoside, aminopenicillins parenterally in a patient with endophthalmitis. It does not reach the vitreous to give a sufficient enough inhibitory dose. Oral steroids, if it is bacterial endophthalmitis, prednisone 30 milligrams a day for 5 to 7 days is what I would give. And vitrectomy, I would suggest an earlier vitrectomy, considering the implications, better chance of vision and eye salvage, and also helps us get a valuable specimen to identify the causative organism. So we may land up with eyes like this if it is a gram-negative organism. The first day, second day, cornea is opaque and then can't see anything. We may have to resort to a PK plus vitrectomy. So here we have done a 6 millimeter cannula, then open up the cornea and put the keratoprosthesis. And then you can see how it is inside. It's a gram-negative infection. Like the retina is almost all the time it's gone, kind of. So the posteriorly, it's actually the vitreous cortex with a lot of exudation. And earlier days, we used to just do a core vitrectomy and come out, but like now we do a little bit more aggressive vitrectomy. As you can see, once the PVD is induced, you can see the posterior pole is reasonably healthy. But this patient had necrotic peripheral retina with the retinal detachment. So we had to cut the retina, do a retinectomy. That's the retina which is floating around in the periphery. Put perfluorocarbon liquid, reattach the retina, and put oil to reattach this eye. So other adjunct steps may have to be done along with vitrectomy, like removal of the IOL and wash the anterior capsule and wound resuturing. And as I showed, vitrectomy plus tamponade can be done. So do we use silicone oil in these patients? Usually not necessary in all patients, but like in this situation, we may use silicone oil a little bit more often because silicone oil is inhibitory to pathogens. And in a cluster, we probably use it a little bit more frequently because it allows fundus examination, early vision recovery, reassures the patient that eye is going to be okay, and treats and decreases the risk of retinal detachment. We want to take a little extra care in this patient. We don't want things going further wrong in this patient. So probably a little bit more use of silicone oil in a cluster is required. So there's the end result of the surgery which I showed. Follow-up treatment would be change antibiotic based on microbiological analysis, and intravitreal antibiotics are repeated every 48 hours. Less threshold for vitreous lavage or revitrectomy. If the vitreous is not clearing in the post-operative period, we go back inside and wash the vitreous and remove the inflammatory material collected. And the topical antibiotics and steroids are continued for the next 4 to 6 weeks. Steroids are tapered slowly, and frequency of antibiotic application is decreased over the weeks. So if it's an MRSA-resistant endophthalmitis, then we can give intravitreal vancomycin, and if it's a vancomycin-resistant endophthalmitis, these are the other agents you can use. Intravitreal linezolid, quinapistin, danfopristin, and daptomycin can be used. Fungal endophthalmitis, we repeat the intravitreal injections over a longer period of time. It can be 2 weeks or it can be even a month. And if necessary, I alternate. One day amphotericin B, the next day could be voriconazole. I alternate like this until the infection comes under control. Oral and parenteral antifungals are used for about 2 to 4 weeks. Last bit is about like povidone iodine. So you can use povidone iodine in the vitreous cavity. It's bactericidal, non-toxic, and the solution is effective for 15 minutes. So need to prepare a fresh solution every time you want to give it intravitreally. An intravitreal injection prior to vitrectomy has been studied in one study where they have given 1.25% of 0.1 ml, and 3 to 5 years before vitrectomy, they inject inside, they go inside and do a vitrectomy. But you can leave the povidone iodine in the vitreous cavity as a kind of an agent as well. So it's about like the dosage is 1.25 ml in 10% or 2.5 ml of 5% povidone iodine, which can be put in the infusion. And that infusion can be what you run through during the vitrectomy. At the end of the surgery, you can leave with 0.1 ml of 5% povidone iodine, and that can also be bactericidal as well. So to summarize, let's not presume that it is stars. Check vision, start prompt treatment. It's important to identify the organism. Aggressive treatment, all routes of delivery of antibiotics if necessary. and lower threshold for vitrectomy, lesser threshold to use alternate antibiotics and povidone-iodine. Thank you very much.
Thank you so much, sir. We've identified a cluster. We've kind of hopefully managed it to some extent. Next is to tell the patients and their family as to what has happened. So invite Dr. Padma Paul from CMC Vellore to kind of share with us what are the models that are available when you have to communicate with both patients and their attenders.
Thank you so much, Dr. Kaushik. I hope in the next few minutes I can walk us through the purpose of communication, dealing with the stakeholders, some of the options that we have for this process, and whether we can ever be prepared for this, and what can we do if it does happen. So does communicating about endophthalmitis qualify to be breaking bad news? Even if it's not life-threatening, loss of one sense, because it's a potentially blinding condition, it does qualify, and it has to be done with care. If you walk with the patient, it may not be so bad after all. So why is communication important? Patient's comprehension determines the compliance, the emotional adjustment, satisfaction with medical treatment, and the psychological state post-communication. You have to remember that this is not just one patient. In a situation of a cluster, ineffective delivery increases anxiety almost exponentially. Potentially bad news has to be delivered with professionalism, patience, and empathy in a situation where the outcome may be uncertain, may or may not have a negative impact, but you have to prepare them for a worst-case scenario. When you're dealing with a cluster, you're dealing with more than one patient and families, sometimes communities and other hospitals. The challenge is that the eye care system may be implicated. So physician is also under stress. In a cancer situation, you're not responsible. Here, you're short of time. You have to make these difficult decisions, do these endophthalmitis vitrectomies through the night, at the cost of the antibiotics, additional consenting, and sometimes, if you don't have vitreoretinal services, refer them for further management. The scenario is constantly changing, requiring updates. So who are the stakeholders we're looking at? The treating surgeon has to deal not just with the patient and the relative, management authorities, community which may be angry, and the government which is looking at you. And it's not just one set, but in a cluster, there are several. Remember to customize the communication to the patient at hand, because different patients may be at different ends of the spectrum. The relationship starts at the time of informed consent, so the patient in some part of the hard drive knows that this was told to me as a remote possibility. One important step is to decide as a team what is the message you're going to convey and stick to it across the board, because the relatives will try to meet different people of the team to find out more information. Who should communicate? Preferably, it should be the head of the unit or a senior consultant. Managing the media, etc., can be done in partnership with the management, but the physician has to be directly informing the patient. What has been found is that this important part of treatment is very casually overlooked in our training programs. Everybody has expressed the need to be taught this kind of communication, and it has worked in some pilots that you actually teach residents and fellows how to communicate under these difficult circumstances. So the goals of communication are to gather information about what the patient already knows so that you can take it from there. Give information in an understandable layperson language, support the patient, express hope, the treatment plan, and the outcome. Important considerations before the interview is to confirm facts. Do not go and talk to a patient depending on the findings of a resident. You may regret it. You have to be composed yourself before you speak to the patient. Be actively listening and give the patient time to process what you're saying. All information should be based on evidence and understanding, and make sure you document what has been conveyed. After this, you will have to periodically update what has been said and patiently answer each time, especially the relatives. The most commonly used approach is spikes, which was elaborated by Bale et al. used for oncology, but seems like it could be adapted for this as well. Setting is what S stands for. Have a private setting, introduce yourself, have adequate body language. The physician needs to minimize any evidence of nervousness in their own tone or body language. Involved relatives so that they can support and help for the patient when the patient is not in a condition to process what you're saying. Manage your time well and avoid interruptions. Before you tell, ask. The P stands for perception, so that you know where to take off from. Also check that the patient is not in illness denial. You are saying that this is a difficult situation. Patient doesn't want to hear it, so hears it like, oh, it should be all right. Then you ask the patient if they're ready for the rest of the information that you want to give. Always refer to the team collectively as we rather than I, especially relevant in endophthalmitis as the eye care providers, reviewing information of several patients and sometimes divulging this to the public if necessary. The most important thing, as even conveyed by patients, is the content. Remember that the patient is very astutely observing. If it knows that the system is designed to pick this up early and treat, you're in a better situation. Once there is a suspicion of cluster, tailor the information for each patient. Use simple words, avoid excessive bluntness. We should gently alert the patient that there may be an issue. Sometimes we call them from home if they've been operated on the same theater day. It's good not to alarm them, but just to warn them gently using kind words. Once there is a suspicion of infection, we have to convey about the testing, the need for injection, need for surgeries, and tell them that there is treatment nowadays which can actually handle it if possible. Don't give large chunks of information at a time, and definitely not say nothing can be done. Be prepared for us to be asked more questions. If we have had to refer the patients for a vitrectomy, stay in the loop and remain involved. Respond to emotions with empathy, needless to say. Summarize what has been said so far and then go on to the strategy of what the treatment plan is going to be. Share the responsibility for decision making. It's very distressing if the first time you hear this is when you have been called into theater to be given an intravitreal Avastin. The only experience that has been reported in ophthalmology is in sharing bad news about glaucoma. Patients have said that 1 in 3 felt that the doctor was saying incomprehensible terms, and that many doctors downplayed their condition. However, training residents has shown that outcomes have improved, so it may be worthwhile to consider this as a preemptive exercise. The important don'ts: we should not make judgmental comments, we should not distort the truth, withhold or overload with information, or give false reassurances. Do effectively communicate with patients with the right balance of honesty, empathy, and concern. It's very hard to do. This reassures the family and the physician and protects both from the onslaught of misinformation that may come through the media if we are not careful. So patients did say that the most important thing that they would like to know is correct content, along with other supportive dimensions. Other alternate models are the ABCDE models, which are very similar to the SPIKE and the Piotr protocol. Most important barrier to effective communication is that as a result of this anxiety and burden of responsibility, we may go mum, which means you don't communicate, and that is a dangerous situation to be. So what can we do? We here in this room hope and pray none of us need to be in this predicament, but it is not unwise to, or it's wise to be prepared for this. Train a team, train our residents, and have a standard operating procedure in place should you ever have to reach this. Support colleagues at the time of the crisis. This cycle of communicating, updating, reviewing has to go on constantly till the crisis has blown over. So the take-home message for the doctor is to be available, be vulnerable. That means you have to face anger and be questioned at all times. The patient has to be part of the process and participate. Relatives have to be informed, support, and retain information that the patient may have missed in his anxiety. As has been said, do it badly and the patient will never forgive you. Do it well and the patient will never forget you. Thank you.
Thank you, Dr. Padma. Now I would like to request Dr. Uday.
Good evening and thanks to Dr. Kaushik, Vision 2020 and the organizers for this opportunity. Before I talk about investigating, there are a few guidelines which are available. So one that we are decoding right now, Vision 2020 Right to Sight India guideline. Government of Gujarat has published a guideline. There's one shown by Dr. Harpreet, also is from Royal College of Ophthalmologists. And AIOS task force meeting had occurred long back. The guideline is probably still under preparation, but we may see AIOS guideline also soon. These guidelines are available on the portal of Vision 2020 and Government of Gujarat. Anybody can download and make use of. Before I go into the investigation, there is an adverse event reporting committee of AIOS. Online reporting is possible on the portal of AIOS. The information shared there will remain confidential. 2 or more cases, as mentioned by Dr. Harpreet, is considered a cluster, and that's why it needs to be reported. Be it even a task, it should be reported. Due to non-reporting, for several reasons, many episodes go unnoticed. I differ from Dr. Harpreet. Clusters in India are more common than we think about it. Every month maybe a cluster is getting reported, and that is only about 1/10 of all the clusters happening in India. Once we report, the committee gets notified and further action is taken based on evidence. So I request everyone, all the AIS members, to report adverse events on the portal. Regarding the guideline, I'll be talking about the investigation into the cause. Dr. Shanmugam has already told us about the treatment of the patients. Now we need to investigate into why this has happened, where things have gone wrong. So first thing is required to formulate a team that will investigate. There can be a microbiologist, an ophthalmologist, a theater nurse, clinical risk manager, and a hospital manager member of this committee. If you don't have a microbiologist, you can have somebody from outside, not necessarily you'll have a microbiologist in your team. There can be 2 different types of investigation. One that you do it yourself and government may have ordered, or an inspection committee may have been sent to investigate this. Not into the ophthalmology, if it's a general healthcare related cluster infection, any cluster is an emergency. So one needs to begin investigation immediately, and one needs to know background rate of infection. Dr. Harpreet mentioned in India we have maybe 0.1% as our background rate of endophthalmitis, but all of us need to understand our own rate of endophthalmitis. We need to confirm the existence of outbreak, laboratory diagnosis using microbiological methods. We need to create a case definition. However, in our case, it's easier endophthalmitis. Only thing we need to differentiate is from TAS. We need to develop line listing by identifying and counting cases or exposures. We need to describe all the surgical data in terms of time, place, and person. We need to remember the patients may have been sent home, because generally we discharge our patients after a few hours from the hospital. So we need to know how many patients are at risk. We need to look at the changes that may have affected the rate of infection. For example, a new staff was recruited in the team, new procedure was being performed, or recently a healthcare worker to patient ratio has changed. Like in Western India, the workload doubles during winter. There's a seasonal variation. Then a new construction going around the theater. And we need to communicate this information to relevant personnel. We need to screen our own staff members and environment. We need to write a proper report, preliminary report, and a final report at the end of complete investigation. We need to summarize investigation and recommendations to the appropriate authorities, and need to implement long-term measures to prevent similar outbreaks in future. Coming to the investigation of cluster endophthalmitis in particular, we need to remember that most of the times it will be failure of sterilization that will lead to a cluster infection, whether it is sterilization done in the hospital or we procured some material pre-sterile from the market. So what all areas that need to be investigated: environment around the OT, pre, intra and post-operative practices, cleaning and sterilization practices, and microbiological screening needs to be undertaken. Regarding environment, there may be some construction going around, or the eye theatre may have been used for some other surgical activity other than eye care, or some septic surgery was done in the same theatre just before we took on the cataract surgery. Again, I'll remind you, we need to look at what was common, because clusters will occur only when common items are used without re-sterilization in between surgeries. So for pre-operative practices, of course, it could be a staff member who may be passing on infection, who may be having URTI, LRTI, skin infection, anything, and is still working inside the OT. However, the other practices also need to be looked at so that we understand whether the protocol that has been followed for cataract surgery is up to the mark or not. There are NPCB guidelines available, there is AIOS guideline available, we have a separate guideline for Government of Gujarat also. Rajasthan government also had published a separate guideline. So we need to follow the guideline particularly given by the government, which will be legal binding to all of us. As far as intraoperative practices are concerned, how many times we are scrubbing, or whether at least we are changing gloves or not. NPCB guideline has made change of gloves mandatory. We did not talk about the frequency of scrubbing. Then fresh set of autoclaved instruments, whether it is used for each surgery separately or not, that needs to be looked at, very important. And whether instruments are left exposed for long periods of time. Sterility and expiry date of pre-sterile material that is used, maintenance of no-touch technique within the theatre, and we should cross-check all the records like patient name, surgeon's name, assisting staff's name, date, which operation theatre, which microscope was used, the type of surgery done. Then in terms of IOL, viscoelastic and saline, the batch number, their sterility indicator, and expiry date need to be checked. I have seen expiry dates gone when the IOLs were being implanted in front of my eyes when I was doing clinical audit of some hospital. We need to look at the logbooks, so we need to check the duty roster, the autoclave records, and we need to check the infection cases also. Post-operative practices directly are not important, but again for the purpose of protocol. Cleaning and sterilization, whether the sterilization is properly being monitored or not. Many times ophthalmologists tend to say that it's not done by me, but we as surgeons are responsible to cross-check whether the activity was done properly or not. Similarly, fumigation and other clinical activity records need to be checked. Proper washing and drying of instruments, particularly the cannulated instruments. Autoclave maintenance and servicing need to be checked. Storage of sterile material need to be checked whether it is done properly or not. Method of packing and loading for sterilization need to be looked into, and date of purchase and proper functioning of the equipments also need to be checked. We need to take cultures from sterile items and non-sterile items. This need to be done on regular basis. However, when a cluster has occurred, we need to recheck everything. And the significance of the organism identified must be decided, particularly if you find the same organism from the patient's eye and from sterile material, then it becomes causative. So when trying to determine the cause, we need to look for common factors, and most of the times organisms enter from surgical instruments, irrigating fluids, or by contamination of the implant. Whatever is going inside the eye can be the causative. I'll not take time in talking about this, but this is taken from one of the inspection reports. I'll not name anybody because these are confidential reports, but the inspection committee looked at the infrastructure part also, human resources related factors also, the record keeping was also looked at in detail, protocol followed inside the OT was also considered in great detail, and statutory requirements and laboratory reports were also looked at. So friends, we need to be very careful, and it is at times difficult to investigate this, but it's better to prevent it. Dr. Harpreet did mention about the green, amber and red alert. It's called traffic light model. This paper is available on the internet. If the p-value of your infections against the number of cases done falls in green, you can still continue to operate. Red, we must stop completely. So reminding you the do's at the, to sum up, we need to stop operative work. We need to recall all the patients operated on the same day for follow-up. We need to check if it was done by the same surgeon or the same assistant or under the same microscope or using the same batch of irrigating fluid or viscoelastic or whatever, whether autoclaving work was done properly or not, whether fumigation was done properly or not, whether sterility of the pre-sterile items which were used was proper or not. We need to set up an investigating team and start working immediately. We must inform the government officers, take culture swabs, do a complete and thorough cleaning, cross-check all the activities of sterilization and pre-operative workup. We need to check the efficacy of the autoclave machine, run a complete check of all the activities as per monthly checklist, keep a close watch on all the patients who are operated, and if traffic light model suggests that we can continue, we can continue. Otherwise, the surgical work needs to come to a stop. Thank you so much, and we hope and wish that nobody ends up with a cluster infection. Thank you.
Thank you very much, Dr. Uday. I would like
Had a great time putting together this guideline. It was a lot of learning for us last year. So reputation is something that is very, very critical. And like Socrates said, the way to gain a good reputation is to endeavor to be what you desire to appear. So that makes it even more important. Quite often you'll see reports like this. So this is very recent, as early as February, where under pressure or various things, the Medical Council in Gujarat actually suspended the license of 3 surgeons once a cluster was reported. So nobody is waiting for the investigation to happen. Nobody is waiting to find out what's happening. But quite often, the media is going to be at it with the name of the hospital, with the name of the people involved, where they're going to say that botched cataract surgery, your years of experience is going to be written off in a bat of a line of just one post going viral online. So we know that avoiding crisis is essentially impossible. So it's important for us to plan as to when it happens, what do we do? Not about if it happens, what do I do? And as has been shown by eminent brand gurus like Philip Kotler, reputation is very hard and time consuming to build and is very easy to damage and lose. And they are very important because they reflect the behavior of the company on a daily basis. So this is something that we can also extrapolate to us sitting in eye care, especially in a crisis environment. Now imagine a fire. A fire requires 3 elements. It requires fuel and oxygen. It requires heat and energy. It requires a catalyst like oxygen. Now in a cluster-like environment, what are the 3 elements? The fuel is the cluster or the actual outbreak. The heat of the public opinion forms the heat, the energy to that entire fire. And by you not reacting to it, actually acts as an inverse catalyst. So that can actually allow others to step in and build the narrative and kind of ruin what you've attempted to do. As with real fires, any one of those 3 you cut, if our reputation is bad, us being able to recruit our colleagues becomes very, very difficult. Most of us who are handling large community eye care organizations are dependent on resources. So donors would walk away if your reputation is tarnished. Warren Buffett has said it takes 20 years to build a reputation and 5 minutes to ruin it. If you think about that, starting today, you will start thinking about what you want to do to protect your own reputation. And it is very clear that the experience that the patients have, it builds the reputation and the information that they have. So it's very critical that what the public hears from patients who've been through our system, again, is going to kind of influence what reputation gets built. How we handle media, how we kind of work with media, police, other governmental agencies is going to build a long way in terms of how they're going to respond to a time of crisis. When we consider any crisis, we are very aware about the outside world. We're worried about government, we're worried about media, we're worried whether the police are going to slap a non-bailable arrest warrant against us, but we forget that the most important stakeholders are actually internal. It starts off with the patient and the caregivers. If we've communicated well to them, they become our champions, saying, yes, there was a problem, but the hospital is going out of the way to handle it. Our employees are our biggest ambassadors. They can tell the world that, you know what, they always do this. They keep reusing it. Last year itself, we asked them for a budget increase for an autoclave. They refused, and we were told to manage with a pressure cooker, for example. I'm being very extreme, but this has happened, where the employees during an inquiry have actually told what happens, and that has put the entire hospital at risk. Government, service agency, donors, they all form the entire ecosystem. 2 examples, Maggi. It's a brand all of us love. It is our comfort food. 2015, there was a case where a media report said that there was a harmful chemical. From a company that sold about 15,000 tons a month, it came down to 0 tons in a matter of 6 months. It took them a further 2 years to again build back their reputation. Let's look at something even more recent, Paytm. They were on IPO, they were the blue-eyed boy of all startups in the country. Their share value crashed 20% because RBI said that you cannot onboard more customers because your reputation is at risk. So this is what happens not just to us in eye care, but every industry in the world. Reputation is very, very important. And during a crisis, it becomes really difficult because there's a lack of information, because nobody knows what's happening. We ourselves are trying to figure out what's going on. There is a pressure to respond. You can very easily lose control of what message is going out. Rumors are flying. Your colleagues are not going to be particularly helpful to you if you've been nasty to them. They are going to again say that, you know, they always kind of do this. They always take up more than they can chew. Things will escalate. Today we are in a social media world where in 15 seconds, a video message from within your hospital can go viral. There will be scrutiny whether you like it or not, both by media and community members. And we will feel attacked. As a doctor, you will be attacked. As a leader in the institution, you'll be attacked. And you will attempt to blame others and become very defensive. These are some things you need to be very careful. So it's very important for you to form a strategy. We've kind of shared some of this as a part of the guideline. You should make sure that there is what you want to project yourself. If you're saying that you're high-class, world-quality care, in terms of your delivery, you have to be that. You can't have an infrastructure that is third world and say that I'm first world. So it is very important for you to make sure that it is not just the gimmicks that you're doing, but the actual activity that you're doing. And once in a while, measure and see how the various stakeholders are perceiving what you do. It is important for us to have a plan. It is important for you to draw up a team in a one-man-led department or a one-woman-led organization. It may not be possible for you to have a team, but be clear. Tell your staff who will speak to patients, who will communicate to any hospital that the patients are being referred to, who will be the interface to any sponsors, partners, government. This, whether you're a one-person organization, 100% organization, is very, very important. Second, create checklist. How will the immediate care of the patients be? What is the protocol to transfer patients out if you don't have the ability to handle them? What is the investigation modality that is there? What are the registers? All of this will come back to help you in the terms of protecting your reputation. You're able to show these documents saying, this is what we have done. This is our checklist. This is what we have done. This is how we have managed it. And be available. Don't hide yourself. Don't lock yourself up. Like I think sir mentioned, or ma'am mentioned, there's a chance for you to think suicidal. It's important for us to be aware and ask for help. There are organizations in your city. There are organizations like Vision 2020. AIOS has their own advisory committees that are available. Reach out to them and ask them for help. It need not be your battle alone. Lastly, create a template with which you can communicate to the media. It is very, very important. Have a template for death. Have a template for any adverse event that happens. First, make sure that the template has you apologize for what has happened so that you don't add fuel to fire by denying it. Second, be clear about what the incident was, how many patients were affected, what have you done to actually ensure optimum recovery and outcome, and what proactive measures have been done to identify the root cause and how you're going to be handling it. A simple thumb rule, what would you do if you were in a situation? If you were a patient, if you were an attender, how would you have wanted the communication to be? That kind of will set context to how you're communicating. As long as you remember that, put yourself in a patient and an attender shoe who possibly is never going to see the world again, who possibly is going to have his eyes eviscerated possibly, that will very clearly tell you, saying that how are you actually communicating to it. So it's very important to be sensitive because emotions are high, and don't make it personal. Transparency is very good for you to put together a truthful, holistic picture, and you have to act in real time. You cannot procrastinate. You cannot say that I'll wait for the weekend to be done, I'll wait for the lab reports to come. If you're waiting for the lab reports to come, let the world know that you've sent the samples to the lab and you're waiting for the reports to come. Until then, you don't know. Rather than say no comments or we're waiting, that's what the politicians you see do. And it ticks you off saying, how can you not have a comment? It's something that is so close to us. So to sum up, take responsibility, be proactive, be ready for a social media backlash, apologize and take action, monitor, plan, communicate, be the first to understand the situation, avoid being knee-jerk, and turn off the fan that can fuel the fire. It becomes very, very important for us to kind of handle it. The QR code will take you to the guideline. It is available on the Vision 2020 website. We've also uploaded it as a part of the handouts, as a part of what the AIOC asked us to. So you will be able to access whatever information that we have shared as a part of this. And to the last talk of this instruction course, I invite Dr. Mahesh Ji, who is as passionate about legality as he is about vitreoretinal surgery. And he helped us put together this chapter that looked at legality and how important it is for us to understand. So, sir, over to you.
Thank you, Dr. Kaushik. Actually, I took a legal aspect as a time pass during COVID. And sitting in this hall, I feel like watching a horror movie. I attended all the other halls. We were all relaxing, talking about something, looking at WhatsApp. Here, everyone is very... so this is the final slides that will... anyway, all of us know that we will be liable if we make a cluster endophthalmitis. There are plenty of avenues by which you can be sued, or patient can go take a criminal, give a criminal case against you in the police. They can go to the medical council. They can go to consumer protection, consumer court. They can go to civil case. They can give a civil case. All these are possible. If we don't mind about all this, that comes later. We can somehow deal with. But the initial part is the most important thing in a cluster endophthalmitis. So there is something called medical negligence, which is defined by Jacob Matthew versus State of Punjab. It should be some breach of duty caused by omission to do something or doing something which a prudent or reasonable man will never do. So there is something called negligence. None of the doctors, none of us will try to destroy the vision of a patient. That has to be very clear. So if you give a standard of care, most of the court of law will leave you. Because I went through all the endophthalmitis Supreme Court and High Court orders and everything. And 98% is in favor of the doctors. Only 2% is this thing is against the doctors because of some very bad omissions in the records and other things, or management. So 98%, the court and the law is with us. So that is one thing. Now, having said that, there are a lot of other things involved in a cluster endophthalmitis. We have a bad outcome. It is not our fault actually. Like Supreme Court has said, a bad outcome of a surgery is not the fault of the doctor. It is possible if you have taken a proper consent. That already we have mentioned. So in a case of medical negligence, they assess, they apply what is called Bolam's law, Bolam's test it is called. So first of all, there should be a standard of practice in cluster, like Vision 2020 or AIOS has given a standard practice. Just are you sticking to that or are you deviating from that? Second, the defender has not adopted that policy, that there is gross omissions in the practice. And that has resulted in something that the doctor did which is not standard of care. So these three things are there that should be there to prove that you are negligent. So like I said, standard of care is there. Like the patient comes, then you have to do all these things as the MPs are told, vitreous stab, intraretinal injection, vitrectomy, all the things we have done as per this, and it is recorded properly in the in the hospital. So that part is taken care of. Now, the consent is extremely important. What happens in many places, in CAM cases, they give a blanket consent. Like just sign here, they will sign, and some fill something. This consent has no legal value. Ideally, at least it should be written that I have read in the patient's handwriting, I have read the above things and understood, and at least that line should be there. Many times it is blanket consent, especially in high volume CAMs. So Supreme Court has said that also, that you should have a proper consent which is legally valid. And another thing is, RDO sir has gone. Yeah, there is CAM cases are not, CAM cases does not mean there is no compensation. CAM cases are included in compensation because ideally free treatment means free treatment to everyone. If you charge few people, if you don't charge few people, it is not free. So in that case, make sure, understand that CAM cases are also liable for compensations. And as I said, there are a lot of cases in Supreme Court and which has ruled in favor of the doctors if you provide a proper treatment. Can criminal proceedings be taken against ophthalmologists after cluster endophthalmitis? This is very, very gray area sort of thing. Ideally, if you apply section IPC 304A and 304, that there should be a death. In cluster endophthalmitis, there is no death actually. So 304A cannot be applied. But there are something like 3337, 338 and all, where there is a grievous hurt, loss of vision is there. So in these things can be applied by the police, but it is not amounting to for criminal negligence and arrest. Usually this should not. So, but there are other problems. In Jacob Matthew case, Supreme Court has said there should be severe recklessness and disregard to the safety of the others. And there should be a mens rea, which will not be there in a doctor's case, in a case of endophthalmitis. So, Indian Penal Code 1860, which is going to be changed to Bharatiya Nyaya Samhita from June, has lot of sections, and in section 176, it is mentioned that death on operation table should be informed. And it is advisable to mention unexpected rare complications to the police. So this is a gray area. I will talk about that later. And 304 and 304A usually cannot be applied unless it is a death. We have seen that also by anesthesia complications and all. So 319, 320, 338 is usually given. Now, there are other Supreme Court guidelines like Kusum Sharma versus Batra Hospital, all these things. They mention that a professional doctor is not negligent merely because of a complication or a difference in opinion or something like that. So they should not be harassed. This also is a verdict that can be quoted by many of us. Now, suppose a patient's relative files a case against you, like group of patients files a case. The police can come to the hospital and they will do an initial investigation, and then they will write an FIR. It is written by police, first information report. Based on that, they can do whatever they want. So if they think that there is a big problem, and they can seal the hospital at least. Even if they don't arrest you because there is no death in this, they can seal the hospital so that you don't tamper with the. There are different government orders in Kerala also. It says that they should form a committee of collector and the DMO, district medical officer, and experts, and based on the report, police should take another criminal case or not. So this is ideal thing, but this does not happen always, because many times if the police want to harass the doctor based on the pressure of media and politicians, so they can do it. They can arrest the doctor on Friday evening. But if such a thing is happening, you can always take an anticipatory bail, and so that you don't go to that extent. Always take an opinion of your proper lawyer, good lawyer, not this thing. So procedure for bail, I don't have time to. So do's and don'ts, I have already told. Don't panic, but I will also panic. That is different. Don't manipulate and tamper. Somebody you can, in the hospital, your team, one person can look after the documents completely. You can't do everything. So one person can look. Don't do unlawful things, unethical acts, like and don't neglect treatment. MPs are told that proper treatment. In the panic, this thing, don't neglect treatment. Inform police whenever necessary if such an inquiry is there. Extend all cooperation to the police. All these things, preserve documents, and probably help of your local IMA or all AOS or Vision 2020 or somebody. And Justice Markandeya Kadju has clearly said court must refer complaints of medical negligence to competent doctor or panel expert. It is necessary to avoid harassment to doctors who may not be ultimately found to be negligent. So they should not arrest any harassed doctors. This is a landmark judgment by Markandeya Kadju. But in real life scenario, is this what is happening? I don't think, because police with the pressure, first people who come inside will be the channel people, so that they will come and interview the doctor, and by the time there will be problem, and then police will come and arrest the doctor. So this is happening first time. But unfortunately, there is no, I don't have any answer, but to how to tackle all these things. These are some of the outlines I can just say. Probably we should have a proper legal opinion. You should have a legal advisor. All these things you should have. And the CAM cases is not very simple. Actually, most of the complications and procedures are happening in CAM cases. And free doesn't mean that you are giving, you are not responsible for the outcome. Most of the problems are coming in CAM cases. So these few things I will wind up. Thank you very much.
Thank you so much, sir. I think we have time for a question, if at all. In the meanwhile, if there are no questions, I would request the instructors to just come on stage so that we can get a picture together. So in case there are any questions, please walk up to the mic and ask in the meanwhile.
Sir, sir, is it not better to give piperacillin initially itself, Piptas, because many of these are Pseudomonas. Because nowadays